This lecture explains the concept of health disparities sociologically. From this perspective, health disparities are social, not biological or genetic phenomena. When sociologists talk about macro level inequality, whether it be national or global level, when talking about inequality in health, illness, disability, we tend to do so in terms of something called health disparities. Health disparities are differences in predicted outcome and actual outcome when it comes to contracting illness or becoming disabled and managing the symptoms of illness and disability or the impact of illness and disability on one's ability to participate fully and independently in social life. Medical sociologists are interested in more than the mere existence of health disparities in the population. So it's not just that these disparities exist, it's that they are not random, that they were preventable, and for US sociologists, it's that they are the result of intentional policy decisions at institutional, local, state, and federal levels here in the US. So, policy decisions to ignore prevention of a risk or to ignore mitigation of a risk are key to understanding how and why health disparities become systemic. Also, very important is the system itself. Why? Well, referring to the system and blaming the system are two of the ways that individuals acting in roles with decision making power normalize health disparities as part of US society, and in doing so, draw attention away from the preventable aspects of health disparities. So they frame these health disparities as inevitable when they're not. Medical sociologists studying health disparities tend to push back against this notion that some people are just inherently healthier than others. This notion is sometimes referred to as genetic or biological determinism. The idea being there is an overemphasis on biological or genetic differences as factors shaping health disparities. So it's not that they are not factors at all, it's that very often they're not the only factor. So, environmental factors are often necessary prerequisites to triggering something called genetic expression. So, actually seeing some genetic variation. And this means that much of the observable genetic difference ends up being social. Not all of it, but a lot of it, at least when it comes to health, illness, disability. To ensure that we aren't participating in genetic and biological determinism, when taking a macro approach to the examination of health disparities, we need to keep a couple of things in mind. Most importantly, we need to keep in mind that macro level effects, these larger global or societal level effects, are inextricably connected to action at the meso, the middling group level, and micro levels, the individual level. So, returning to the system here, this means we cannot look at the system as operating independently of individuals and groups within it. When we talk about the system or systemic effects, we cannot forget to account for how the system and these effects are upheld, how they came to exist in the first place. Actions of powerful individuals, especially those linked to powerful social groups like political parties, are important agents in upholding systemic inequality. We use social factors to predict health disparities, and they tend to be social and contextual factors like race, class, gender, sexuality, disability, geography, things like that. Things that are shared by individuals, which is how we're able to count things like incidence and prevalence and how we know that there are patterns of things in populations. But if we aren't mindful, we risk framing health disparities as inherent based on these characteristics and not as something that are the result of the use of policy to target people and groups with these characteristics. So, for example, say we want to look at racial health disparities. Instead of discussing them in terms of people of X race are X times more likely to develop X condition than X other race. We want to take a closer look to identify the reason race is a factor, some reason other than these two people come from different places and look different. So we can say something like parental education is a major predictive factor for X illness in that those whose parents did not receive a college education are much more likely to develop X illness because they are much more likely to work in X sector, which exposes them to something that causes X illness. So, while we would see variation by race in this situation, there are obviously several other confounding factors to explain the increased representation of people with X condition among people of X race. We might say policy prohibiting people of X race from enrolling in medical and other professional education programs is one of the things that helps explain variation and prevalence of X illness by race. Policies of employment discrimination could be another. The point is, a lot of times, even in sociological literature, you'll see discussion of these social factors, things like race, as predictive factors. But they're not biological factors. And sticking with the example of race, for example, discussing race as a cause of illness ignores that racial variation in patterns of health and illness, especially here in the US, is due to policy decisions about race that have gone back for a very long time, generations. It's due to policy about race. It is due to a system premised on white supremacy and the notion that supremacy is something that can be won in a power contest via the acquisition of resources, namely land and wealth. So here, it's not race, it's racism, and specifically racism embedded into policy. So, to give an example, say we're researching during the height of colonization, and we notice that there are increased incidences of death by smallpox among indigenous populations in what we would now call the US. Maybe we conclude that indigenous peoples are more susceptible to complications from smallpox than white European settlers. Doing this would attach the cause of the disparity to the wrong thing. I use this example because we know exactly why this pattern existed, which it did, and we know that it wasn't due to race or ethnicity. It was due to differences in exposure and lifestyle, or exposure that was related to lifestyle pre colonizing. So, smallpox did not exist here until the settlers came. Settlers also had a much, I guess what you could say is less hygienic way of life. If we think of this in terms of COVID, a lot of indoor socialization, very close without any mitigations. Race, in the case of smallpox, was a factor in that the white settlers felt it was their right to explore with no mitigations, and that they made active decisions to be okay with the widespread illness and death among indigenous populations, that they made intentional decisions to even increase the spread, but not because these two populations have different skin colors or are different ethnicities. It's also important to note that our understanding of how social factors and contexts impact health disparities will be most thorough when we account for more than one social factor at a time. So, health scientists like nice, neat categorizations. And so, a lot of times, the supplemental literature will emphasize one or two factors, maybe race and gender, or just race, or just gender. We need to be really careful when we're doing this because it ignores how these factors intersect. So you could be privileged in one area and oppressed in another, and that really matters. If you're only looking at the area in which someone is oppressed, you might get the impression that they're more privileged than they actually are, and vice versa. So, focusing on a single social factor can be incredibly misleading, and focusing on a single social factor risks concealing important information about inequality and inequity. Tune in next time for a discussion of how we can use sociological theory to try to better explain and understand health disparities.